I'm Kristen Elliott. In this video, we will review chapters 4 and 6 for nursing pharmacology. Chapter 4 is cultural, legal, and ethical considerations. Why does this matter? Why do we care about cultural, legal, and ethical considerations? Because culture is going to impact patients' perceptions of medical treatments. Legally, we need to be aware of and follow the law to keep our patients safe. In terms of cultural considerations, we need to assess the influence of a patient's cultural beliefs, values, and customs. Drug polymorphism exists. This is the differences observed in patients' response to medication based on ethnicity. Genetic makeup is going to change how somebody responds to a drug. Cultural considerations may change compliance with therapy. How compliant is somebody in? How do they view the medical system? Do they view compliance as, if I take my medication once in a while, that's enough? Or I need to follow every letter of the law? Environmental considerations. Where does somebody live? Do they have access to transportation? Do they have Medicaid? Do they have private insurance? Are they able to afford their medications? Can they take their medications? Do they understand the instructions you're telling them? Genetic factors, as we discussed with drug polymorphism. You have varying responses to specific drugs. Now, to talk about new drug development. So for a drug to be created, we have to go through this very extensive process. So let's say research lab is going to create a new chemotherapy drug or new diabetes drugs. They're coming out all the time. So step one would be research for a new drug, which is going to start in a laboratory. So they're thinking, hey, is this drug going to work? What do we need to do to get some trials in place? 2, the drugs undergo laboratory and animal testing to answer basic questions about safety. Is this drug even feasible? Is it going to harm everybody? 3, clinical research. So after they've done the animal testing, they're going to start the trials on people. 4, the FDA review. So the drug company, the laboratory, is going to pile all of this information together. And the Food and Drug Administration, the FDA, is going to review this information and say, is it appropriate? Are we going to approve it or not approve it? Step 5 is FDA post-market safety monitoring. So all the trials may have been good, may have gotten the medication out to the patients, and then they notice people are developing renal failure. All of them are developing renal failure. Well, that information would go to the FDA, and the FDA is able to pull drugs and devices off the market. All right, this is something I want you to know. So what is the DEA? So the DEA is a drug enforcement agency. So this is a branch of the government that deals with illegal drugs, people who are using legal drugs inappropriately. So these drugs are scheduled based on the DEA's perception. So how likely is a drug to be abused? So I think of these as risky drugs. I also think if somebody got a prescription for this and sold it on the street, would they make money? So if somebody gets a prescription for ibuprofen, nobody is going to buy it. If somebody gets a prescription for oxycodone, a lot of people would buy it. So that's just my own personal way of thinking of this. So the drug scheduling by the DEA ranges from Schedule 1 to Schedule 5. Schedule 1 drugs currently have no accepted medical use and a high potential for abuse. This would be an example of heroin. We're not going to use heroin as a pain management strategy. This drug is only abused. There's no medical benefit. Schedule 2, we have use for these drugs, but they have a high potential for abuse. Examples of these would be Ritalin. Do we know what we use Ritalin for? Methylphenidate. It's an ADHD drug. And then oxycodone is a component of Percocet. Schedule 3 drug have a moderate to low potential for abuse. An example of this would be ketamine, Tylenol 3 has codeine in it. Schedule 4 has a low potential for abuse. Benzodiazepines such as Xanax, alprazolam is the generic name, fall into this category. So there's still some potential for abuse, but it's not as high as Schedule 2. And then Schedule 5 is the lowest, but there is still some potential for abuse. So Lomotil is an antidiarrheal drug. Lomotil has a weak opioid in it, and that is how it works, by slowing down the gut. So there's some potential for abuse, not a lot, but it still is considered a scheduled drug. Now at the top we see ORS. So this is the Ohio Automated RX Reporting System. So ORS is something put out by the Ohio Board of Pharmacy. This database collects information throughout Ohio and some other states to look at prescriptions. So if a patient gets a prescription for oxycodone in Dayton, and the next day they come to Columbus, say their pain's unmanageable, they need a prescription for oxycodone, the provider could look in the ORS report and say, nope, you just got a prescription in Dayton, I'm not prescribing that to you. So it's really allowed prescribers and pharmacists to cut down on these illegal, well, they're not illegal, on these prescription drugs with high abuse potential. In terms of ethical considerations, we have 5 principles for discussed here. These principles are important for thinking about managing difficult situations. So these principles include respect for autonomy, which means the patient can make their own decisions, non-maleficence, meaning you won't harm the patient, beneficence, you're going to help the patient, and justice means you're going to treat the patients fairly. A few more things about safety. Before giving a medication, you will want to verify name and date of birth before giving. You will want to ask about allergies. And the patient has the right to refuse any and all treatment, including medications. I think we get so bent up on, oh, well, this is how we manage this. You have to do it. The patient doesn't have to do anything that they don't want to do. And that's respecting the principle of autonomy. The patient is able, they are able to make their own decisions. They do have the right to refuse any and all treatment. On to chapter 6. This chapter is about patient education and drug therapy. So why does this matter? Our goal as nurses is to help our patients. When our patients are no longer in our care, say they're discharged from the hospital, assisted living, they leave the doctor's appointment, they need to be able to help themselves and stay safe. Health literacy. This means, does the patient understand what you're saying? You've given a great 30-minute discharge lecture about diabetes and its home management. You used all the things you learned in nursing school. It was eloquent. But the patient doesn't understand. So that's a big issue. Patients' health literacy is their ability to understand instructions, navigate the healthcare system, and communicate concerns with the healthcare provider. So if your patient's unable to do those or feels like they're really weak in those areas, your discharge teaching may have been for nothing. Some tips on how to best communicate with your patients. Use simple, easy to understand instructions. Use a 5th grade reading level or below. So all your fancy terminology is probably not going to be beneficial for this patient, which is why we really need to understand what we're learning and what we're doing, because the more we understand it, the better we are going to be able to communicate it. And then use teach back. So this is demonstrated in the next question. Which action best indicates that learning has occurred? A nurse presents information about diabetes. B, a patient demonstrates how to inject insulin. C, a family member listens to a lecture on diabetes. D, a primary care provider hands a diabetes pamphlet to a patient. So what do we think? So with A, if the nurse is talking to the patient, giving this beautiful speech about diabetes, how do we know that they learned anything? C, a family member listens to it. Well, 1, has the patient learned anything? And 2, how do we know the family member learned anything? D, primary care provider hands a diabetes pamphlet to the patient. That is great, but every time I hand somebody some literature, I just have a sneaking suspicion that they're not going to read it. When I'm discharging patients, I really like to hit on a few key topics and have them tell me, okay, why does it matter? What are you going to do when you go home? When are you going to call the doctor? Who are you going to call? How are you going to use this new medication? Show me how you're going to use your inhaler. So a patient demonstrating how to inject insulin, this is the teach back method. You can evaluate, is the patient doing it correctly? Are they safely able to draw up the insulin? Are they safely able to inject the insulin? You're going to know how much has the patient learned, and are they going to be safe going home? Some teaching implementation strategies here. Teaching learning sessions, considering age-related changes. Your elderly patient may not be able to hear you. They may not be able to see the instructions. Maybe try to print it in larger font. Consider language barriers. Who's going to interpret for your patient? How are you going to communicate with them? Can you print instructions in their language? And you always want to do a return demonstration with things like insulin and an inhaler. And then by using this teach back method, you want to validate whether learning has occurred. To do this, you can ask questions, have the patient provide a return demonstration, check their behavior. This would be things like, hey, bring all your medication into your next appointment. You see that they got their insulin filled a month ago, and you know how much should be gone, and only a third of that is gone. You're going to know that they're not using it. Occurrence of few or no complications. So it'd say, hey, you know, you got back to your doctor's office and your hemoglobin A1C, which is a blood test we use to detect how well diabetes is controlled, has decreased. So yeah, you are on your insulin, you're doing good. As a patient ends up in the ER with a very high blood sugar, you probably know, hey, they're not using their insulin.